Okay, how do you know that's happening in your hospital? How do you measure that? Some people say, well, Matt, the nurse initials on the order that she wrote it down and read it back. Do you believe that? No. So how do you know that? You have to observe. You have to look around, look at independent double checks, see how people are making IVs. Are they making IVs safe? Remember, medication errors occur due to breakdowns in our processes and medication use. Breakdowns in processes. How do you know there are breakdowns in your processes? You can proactively do that with a self-assessment, or you can wait to observe it later on down the road. Also looking at where medications are stored throughout the hospital as well. Data from technology, there may not be a lot of technology use here today, but any automation you buy here up forward, whether it's barcoding systems, you may have Pyxis machines or automated dispensing cabinets or smart infusion pumps. All those forms of technology have reports just sitting inside to be looked at. What can those reports tell you? A lot of numbers here. So another great source of identifying if something's going wrong. So in wrapping this up, the key thing, this is a very quick 25-minute presentation that takes a lot longer, but there are a lot of ways to identify if you have a problem. Error reporting is one piece of the puzzle. And in fact, I'll ask you to change your mindset. And I tell this to everyone in the US all the time. Stop letting the error reports coming in determine what is wrong in your hospital. Because that's an inaccurate picture, and you admitted that, right? So instead, everyone in this room probably knows of a concern with a certain drug in your hospital. Maybe you have a concern with opioids, or you have a concern with insulin. How do you prove that problem? Look at the triggers. Look at naloxone use. Look at your blood sugars below 50. How about glucagon use? Dextrose 50% use. How about your pharmacy phone calls? What phone calls are you making to correct insulin orders? What phone calls are you making to correct orders with opioids? How about any automation you may be using as well? Preparation variances as in observing IVs being made or other ways to directly observe methods. So the key point is error reporting is a small piece of the puzzle. Don't make it this. It's not this. It's this. It's all these other things added together that will truly tell you and identify the problems and risk in your organization. So on that note, let me pass on to the next speaker. I think in perfect time, okay? So next we're gonna have Fakir Ayubi come up here to talk about medication safety in critical care, pharmacist to the rescue. She's a senior clinical pharmacist in critical care in cardiology for the Department of Cardiac Sciences at King Saud University in the Kingdom of Saudi Arabia.
Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everybody. Thank you for the organizing committee for giving me the chance to talk about medication error in ICU. Actually, before I start, I would like to tell you first where we have been in Saudi Arabia and a little history about our practice, and then how did we reach to medication safety reporting. And also, we have a future actually plan that we would like to share all together. So please, I need just a little bit of concentration. I know we are at the end of this very nice symposium, but it's always nice to end up with future plans. We have about 15,000 pharmacists in Saudi Arabia. Believe it or not, only about 3,000 of them are Saudis, and all the others are none. Pharmacy began in 1920 in Saudi Arabia, not by Saudi pharmacists. They were coming from outside the country, and they were able to build the pharmacy profession during that time. The first regulation that was assigned in Saudi Arabia, it was in 1928, long time ago. The profession actually was covering a lots of branches there, and I'm going to cover one by one. Sorry. In order to just tell you what profession we have been in Saudi. As you can see, we have to start with academia, which is the College of Pharmacy. We had the oldest college of pharmacy in the Middle East, in Saudi Arabia. It's the King Saud University, which most of us have been graduated from, not even in Saudi Arabia, even in the Middle East and in the Gulf countries. They actually covered all branches at that time except clinical pharmacy. It wasn't actually a branch that was studied that time. And they started in 1959 with a male branch only. There was no pharmacy college for females that time. The clinical concept itself started in 1976, which is almost parallel to the US. Females started in 1981. This is where the first batch of Saudi pharmacists graduated. Believe it or not, we used to graduate like 20, 30. Now we are reaching to up to 3,000 pharmacists per year. And this is a huge number. The PharmD started in Saudi Arabia in 2001. That was in Jeddah. And now we are following suit all over the kingdom. We have about, as Dr. Hisham mentioned, almost 30 College of Pharmacy. And we are just graduating more and more pharmacists. That's regarding the academia. What about industry? We used to get everything from outside. Now we have 16 manufacturers in Saudi Arabia. The drugstores or community pharmacy, it started as actually a concept of business. It was in Jeddah in 1920 and 1950 in Riyadh. Of course, it developed to independent pharmacy, then to chain pharmacies, and that's why it led us to think about what about implementing pharmaceutical care in community pharmacy? You might say, why is that? I'll tell you that in just a few slides. Why did we concentrate on that? We conducted a study to see the acceptability of pharmaceutical care in community pharmacy. Almost 97% of all pharmacists working there, they know about pharmaceutical care, and they just want us to implement it and get more knowledge. The answer of why did we think of community pharmacy as a source of pharmaceutical care, because 70% of the drug sales come from this area, not from hospitals. So we don't want to neglect this part. We have about more than 4,000 pharmacies, but as you can see, the bad thing is that it's all concentrated in the middle of Saudi Arabia. That's another issue. Then we go to hospital pharmacy, and this is where we are talking about medication safety era. They started as few hospitals, 1925, that was in Jeddah, Mecca, and all this area, then all the other cities. Then we had evolution, and then we went to private hospitals. Now we have health centers all over the kingdom. Again, we would talk more and more specifically about the hospital pharmacy profession in Saudi Arabia. This is where we're going to concentrate about medication safety part. This is actually pictures taken from the King Khalid University Hospital when I was still in the primary school. And look how advanced they were in the 1980s, and that was really amazing. They had the first unit dose system in Saudi Arabia, and also they had the first drug information, and believe it or not, they had also an IV preparation and TPN since that time. Now the hospital that I work in, which is a university hospital, we have all the facilities and services around, even outpatient discharge. We are all now evolution to the part of development more and more practice in our area. Okay, so let us now talk more about clinical pharmacy and critical care. So now we know from where did we start. Let us go deep now about the concept of having clinical pharmacists in the hospital. Actually, it started with a few number of US clinical pharmacists that came to our area, and also some pharmacists who are Saudis and graduated from the US. So most of our trend in Saudi Arabia counts on the US practice more than other practice, although we have some trained in Canada and some trained in UK. But the predominant is a US trained. They actually went there and they established a TDM, pharmacokinetic, and TPN, as I told you. We started King Khalid, King Faisal Hospital, even in Aramco. The first clinical pharmacist in the ICU was in 1983, and that was a pharmacist that's still practicing until now. He started rounding with the surgical ICU team. And at that time, he was able to establish and implement the role of clinical pharmacist in the critical care. Also, we had the first residency program that was approved by the KSU and affiliated by the SHP, and that was in 1984. King Faisal now has, in 1997, their own ASHP accredited and affiliated residency program. So you can see now, we believe that ICU is important. We believe that pharmacist has a role there. We have different type of ICUs, as you can see. All of them are available in the practice. So we really need to concentrate now more about working in a team, because as a pharmacist, you cannot work alone, and that's why you are there. You're an asset to combine all the team together. And I believe in that. A pharmacist should be a leader in this team. You like it or not, you are the leader. Although physicians give orders, but you are the one who's going to lead the whole team to the right decision. I believe that an ICU pharmacist should have a special criteria, and this is not just me. It's actually a study that has been conducted in our hospital. They should have a right and a rapid decision-making. It's a crucial area. You should be able to make a decision. To do that, you should have a strong knowledge and a strong personality, and of course, an experience. Because your experience will lead you to implement pharmaceutical care part, which is identifying, resolving, and preventing the problem that is in the ICU. And doing that will decrease adverse drug reactions, interactions, and inappropriate therapeutic, and also will increase the communication skills in the team that you work in. I believe that not just being a pharmacist makes you a good clinical pharmacist in ICU setting. Absolutely not. As you said, we need a residency program or at least a practice, 5 years practice before you jump into an ICU team. We need the ICU pharmacist for several reasons. The most important part is the guidelines and protocol. You need to first design it with the team and then implement it and assist it after a while, because this will improve the quality of life of the patient. The problem is that in Saudi Arabia, until now, we don't have a good statistic. So we're just going to count on the US statistic, which says that we have a 1 million injury and almost 100,000 deaths because of medication error. See how crucial is this? And why is that? Because an ICU setting is a sophisticated place, and it has always a new technology and new drugs, and drugs also are given in high-risk condition. That's not all. In fact, the patients change dramatically and very fast and very quick. And the other thing, they don't just get 1 or 2 medications. At least you find several IVs in this patient with different type of drugs and interactions. So the common cause of error should be known. That is the lack of communication among the caregiver. And also, it's sometimes related to the calculation of medication dose, and of course, the medication administration. So you have to know the source of error before you set into an ICU place. They did like a small study to say about the problem, how serious is this problem. And they said that in 71 ICU patients, the error was observed in 10% of them. Again, that's a full team with a pharmacist with them and a good setting. And they had 10% medication error. Imagine if there's a place with no clinical pharmacist or the team is not complete. So this is a very actually crucial and a very important point that we have to step in. I did do some kind of literature review in order to see what other people did and what studies do we have. And they found that the impact of critical care pharmacists on enhancing the patient outcome, how come we do that and how did the pharmacist do that? Correcting or clarification of an order, providing drug information, suggestion of other medications, all these rule of clinical pharmacists there. They found that they were able to reduce adverse drug reaction and also the pneumonia caused by ventilators and all kinds of adverse drug reactions. So what about the cost? Sometimes, and I heard in one of our speakers that they said the clinical pharmacists are a little bit expensive. So you have to work on the cost effectiveness of being a clinical pharmacist and hiring one of them. Okay then, look at this. They said the impact of this on the cost, 129 intervention done in 4 months in this study. The intervention was taken either from the chart of the patients or the rounds, and they found that there is a decrease about more than 60% in the medication error, and that's not all. The cost has been decreased to almost about $80,000. So I think thinking about the cost effectiveness, it's worth it. What about pharmacists practicing on physician rounds and adverse drug reaction intervention in the intensive care units? Again, they prevent adverse drug reactions, and there was a study conducted there to prove that, and they found that most of the interventions done by those pharmacists are accepted by the team. A fourth study that has been conducted in King Faisal Specialist Hospital, And it was done in about 19 beds. 300, almost 400 intervention was done there. 94% were accepted, and 55% were targeting the therapeutic outcome. 22% prevent the adverse drug reaction. So again, I think the last study would be the Harvard study that was the most strongest, and it was in the ICU setting. They did it for 1 year, and it was in Boston. And they actually gathered data from different sources in order to see, again, the validity and the importance of having a clinical pharmacist there. 78% of the drug medication errors were decreased, and they were actually telling us that because of the wrong dose of medication. So this will lead to change of the practice, and that's why they conducted some workflow and tools to improve the quality of medication there. And they just went to the online and barcodes and all kinds of elements, tools that will improve the service. Infusion pump, which they call the smart pump, in order to come over the intervention medication errors. The presence of a clinical pharmacist has been proved that it's effective, and it will lower the adverse drug reactions. That was done on every place and every site, but specifically in the ICU sites. And they discovered that adverse drug reactions reported by pharmacists were 0.3, while in other non-pharmacists it was only 0.1. So again, pharmacists has the ability to detect even more medication error than other specialties. What about the principle of medication safety? Doctor, thank you so much for covering most of the elements that I was going to cover here. So again, we need to know what is the definition first, which is, again, preventing the mistake and the improper way of getting medications. And this could be in any process, either in the order itself or the transfer, and whatever. Any kind or any step in the medication delivery could be the reason of having a medication error. The detection, as mentioned before, it could be by just direct incident report. It could be by observation. It could be by attending the rounds. Detection is important, and there's different way of doing that. Depends on what facilities and what equipment you have in the set that you're working in. But you have to put in mind, reporting only is not the case. You have to report, analyze, and sort out the outcome that you got from your analysis. For example, we had actually a very high deterioration rate in the emergency of the Actually, we did a little study, a pilot study about our patient in acute coronary syndrome, and we found that the deterioration rate is increasing instead of decreasing, although we had a big center, cardiology center. So what we did, we implemented actually a checklist to help in improving the outcome of the patient. Because we had the concept, and we trained all the team, that the time lost is a myocardium loss. So this is actually the concept that we built inside the team. According to that, we have 3 goals to achieve. We have to first manage the pain, regardless what type and what kind, what route of administration you're going to use. We have to do a very quick reperfusion of the patient, and of course, treating the arrhythmias. So the whole team has the concept now. We had a checklist, and it was just very simple, according to the guideline checklist, telling all the professionals what to do. For the pharmacy part, we have to cover all these drugs, just at least yes, 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 and then you make sure that your patient having the right dose, right time, and right patient, and of course, that was helping us a lot. Believe it or not, it improved the outcome of our acute coronary syndrome patients, more than 50% of them. So again, pharmacist is an asset. He is the one who's going to design this and work with the team, because I do believe that ICU should be a standardized area. There is no chance for just human problems or mistakes there. We have to work in an evidence-based approach, and we have to reduce as much as we could the medication-related issues. And I think this could be by computerization, could be, or using any other system that will help a lot, automation, and of course, this is part of the future plan of our pharmacy profession. And preventing all kind of like nosocomial infection depends on the site that you're covering there. So I do really have a future plan, and I would really like to share it with you. Being a pharmacist, it means that you are the person that knows everything and just like show it at the right time. I don't expect surgeons, for example, to know about everything. They just know about cutting the patient. But drugs-related issues, it's our playground. I do believe that if we use a very good database, which is we are working on in Saudi Arabia, with using, of course, the wireless and all these sophisticated instruments, with the automation, we can go to the step 2 of pharmacy profession, which is going to the smart service. And that would make the manufacturer, research, and practice all together going to that point, which is the smart concept. If you reach the smart concept, I think we can even go beyond that, which we call the wise service. And this is actually supposed to be the goal of each pharmacist in here and outside in the world. We should think of a wise service. We really need to have all this conducted together. And I'm sure that if we reach to that place, pharmacy profession would be the best, and it is the best all over the world. I'm sure about that. Again, I do really think that pharmacists are the leaders, and they are responsible for the safety of the passenger, of their patients, because we actually do really take care of our patient in a proper way, and we have a very nice communication skills with the team to convince them to take the right and the proper decision for the patients. Thank you very much. Thank you. Oh, there you are.
All right, thank you very much. I'll introduce our next presenter, Samaya Mahid Azabi. We'll talk about Koala's hospital experience in medication safety. She's a senior clinical pharmacist at the Koala Hospital in Oman.
Thanks, Professor. Thanks for all the audience who are still here waiting for the last presentation for today. And today, my speech will be about Khawla Hospital experience in medication safety. And I'll try to cover these points. I'll speak first about the medication safety, and I'll present Khawla Hospital experience. I'll talk a bit about the Pharmacy Quality Improvement Committee, and also I will give examples of some medication incidents happens in the hospital. I will go through our practice in the pharmacy department, and at the end, I will give some of the rules of the pharmacist to improve the medication safety. So medication safety, we can define it briefly as the freedom from preventable harm with medication use. But other definitions we should keep in mind when we are talking about medication safety, and these are the side effects, the adverse drug reactions, and medication errors. And it is very important, medication safety is very important, because medication incidents can occur at any time during medication use process. It can happen during prescribing, transcribing, it can happen during dispensing, for example, monitoring, administration. And daily we will hear news about medication errors. And recent studies shows that serious adverse events in hospitalized patients occur mostly from medications. And moving to our experience in Khawla Hospital, it's a tertiary hospital. There are 518 beds in this hospital, and there are 9 specialties in it. The culture of safety, of course, started with the hospital, and before 2008, there was a quality committee which was dealing with any medication incident, and there was a pharmacy member in this committee. With the expand in the services, improvement in the services provided, this committee becomes a department, and the pharmacy member in this committee becomes a facilitator, a connection between the pharmacy department and the hospital quality management department. So the quality management department in the hospital having a subcommittee, which is the Hospital Quality Improvement and Patient Safety Committee, where the director of the pharmacy is a member in this committee, and they are dealing with any medication incident. They are also working on the WHO patient safety solutions, and these are 9 solutions. The first one, and 2 of them actually, were dealing with medication. The first one dealing with sound-alike, look-alike medication, and the 5th one deals with the concentrated electrolyte solutions. And recently, this department established a quality and safety walk-around, and it's like an audit for the services provided by the hospital, including medication. And if I will talk about the quality, I need to say that we have a quality improvement committee in the pharmacy, and this is to improve the services provided in the pharmacy department. It has been established in 2008, and the objectives of this committee was to assure and optimize continuously the quality of therapy and care in the pharmacy department, and also to manage the potential risks using medications which may be of, let us say, poor quality, and this may result in poor efficacy and poor safety. People in this committee having many roles and responsibilities. They should supervise the department, they should supervise the development, implementation, monitoring of the standards and guidance related to the aspects of hospital pharmacy services and also management of medication. They should design a process map for each pharmacy section, and also they should look if there is any medication with a poor quality. When I will say any medication, I mean the purchased one or prepared for the hospitalized patients. They also conduct a quality audit for the pharmacy technical services and the drug stored in any area in the pharmacy. They are responsible for reporting and analyzing the ADR reports, incident reports, any medication error reports. They conduct training sessions, not only for the pharmacy staff, but also for the other health professionals in the hospital. They should investigate behind any defective medication or expired medication within the pharmacy department. They are also responsible to create changes on the leaflets or order forms. There are many achievements reached by this committee. Until now, they approved 4 policies used in the hospitals. They also approved a high-risk medication protocol, and they are working recently on medication audit tool. They also having a participation in what we call it a root cause analysis and ad hoc committee. I'll give you an example of the root cause analysis. There was a pregnant lady who came to the hospital with a past medical history of hypertension. She had been prescribed methyl dopa to control her hypertension. That patient, unfortunately, when she took the medication, it had been prescribed correctly, but unfortunately, metformin had been issued for her. She took the medication with her for a week. She was taking metformin instead of methyl dopa. And when she was monitoring her blood pressure at home, she still complained from the high blood pressure. She's still having the headaches and the other symptoms. She came back to the hospital, and we got to know that she got the wrong medication at that time. And what we did, a temporary committee have been done to analyze the causes behind this error. And we came with several results after investigation. Staff should aware about the incidents happen and ensure double-checking system. The staff should use her or his own Ashifa account, which is the computer system we are using in the hospital. We should remove all the high-risk medication from the front area, because we found that metformin was beside the methyl dopa, and by mistake, the pharmacy staff picked the metformin instead of it. And try to help the staff who are dispensing by bringing another staff while preparing or receiving indents from ministry. This committee work on 5 medication incidents in 2014 and solved them. They reported 73 ADRs and 39 quality reports, and now in the process of analyzing these reports. They set increase the percentage of reporting of ADRs, quality reports, and medication errors as objectives for 2015. And I will give some examples of other medication incidents occur in the hospital. We have a sound-alike medication error, and a patient, a pregnant lady, have been prescribed hydroxyprogesterone to stabilize her pregnancy. Unfortunately, this patient, she didn't receive it actually. It have been dispensed wrongly for her. Hydrocortisone was issued for her, but thankfully, she didn't receive the medication. After double checking, the patient got her right medication, but it was a dispensing error. This is an example of ADR where the patient took his correct medication in a correct infusion. This was vancomycin given over 60 minutes. But still the patient built rash and redness all over his body. This have been reported, and the result, we solved this problem by increasing the infusion rate to be more than 60 minutes, which help in reducing the side effects. A quality report when antibiotic piperacillin plus tazobactam have been issued to the pharmacy or brought by ministry to the hospital, changing the company. Unfortunately, the treated patient was not responding to